It's 5 minutes after our regular time, so I'd like to get started, please. My name is Amit Bhattacharya, University of Cincinnati. I'm the director of the pilot research program here. I'd like to welcome all of you to our 4th annual pilot research program symposium. Before we go into the details of it, a few announcements. The restrooms are right outside the door, right in front of you when you get out. There are additional restrooms on the left side of the hallway, end of the hallway. And for people who have their posters, I know there is a little note written for you. Just make sure you have your posters removed by tomorrow, no later than 1 p.m. because there is a press release going to take place. So we just want to have the place cleared up before 1 p.m. tomorrow. Okay, with that, just a few words about the status of our program. This is the 4th year. We have funded over the last 4 years more than 70 pilot research grants, totaling about $300,000. And we've been very lucky to have several of our awardees, at least in the last 3 years, based upon their data they collected in the pilot grant, have received several large amount of grants from other agencies. So the return on the dollar has been more than 7 or 8 times. So very pleased and like to give a hand of appreciation to those people who got the grants. So if you've gotten some more grants, new ones, let me know today. So the number goes up, so that's good for us. So in order to celebrate this whole success in our pilot research program, I was very happy to have the director of NIOSH this year come to our program and give a keynote today, Dr. John Howard from NIOSH director. And just a little bit of background about Dr. John Howard. He's the director of the National Institute for Occupational Safety and Health in the U.S. Department of Health and Human Services in Washington, D.C. Prior to his appointment as the director of NIOSH, Dr. Howard served as the chief of the Division of Occupational Safety and Health in the California Department of Industrial Relations from 1991 to 2002. Dr. Howard, after his MD degree, he went on to get a master's in public health from Harvard, then went on to get Doctor of Law from UCLA, and then the list goes on. I think the last one, I hope, is the last one, is Master of Law in Administrative Law from George Washington University in D.C. Dr. Howard is a board certified in internal medicine and occupational medicine, and he's currently a member of U.S. Supreme Court Bar, and he has written numerous articles on occupational health and law and policy. I'm very pleased to introduce and welcome Dr. John Howard to give his talk on changing nature of occupational safety and health. Dr. Howard.
Thanks for inviting me here. I really appreciate it. And I just want to congratulate everybody associated with the program. Looking over the presentations and the presenters and seeing all the representatives from other schools here, it's really great. I think this is a fantastic use of the taxpayers' money. And as guardians and administrators of the taxpayers' money, we at NIOSH have to make sure that we get our value because the taxpayers are trusting us with their money. And I think that I can unequivocally say how much added value comes out of the dollars that go into this pilot program. And I just want to congratulate all of you, not only those of you that have put work in the last 4 years into the program, but those of you who are continuing to do so, and to tell you that are presenting today that you may actually be, oh, you want that too? 2 mics, huh? Okay. Is one electrified so that if I say something? Ah, I see. Okay. So if you present here, I think you have an illustrious career ahead of you because from what I hear, people have gone on to do very good things afterwards. Ahmed invited me and asked me what I wanted to talk about, and I said the changing world of occupational safety and health. And what I wanted to do really was to sort of ramble on for a few minutes about some of the issues that we're all facing, I think, together, both nationally, internationally, in occupational safety and health. I went to undergraduate at the University of California, San Diego, and one of the courses I took one semester was a political science course taught by Herbert Marcuse. For those of you that are into neo-Marxism, you'll know Herbert Marcuse's name. My TA was Angela Davis. For those of you who are old enough to know who Angela Davis was, she wasn't exactly in the Young Republicans. But actually, I was in the Young Republicans in college, and I remember whenever I asked a question in class, Dr. Marcuse would always say, well, our little subversive wants to ask a question. So I'd ask my question, but one of the things that he taught me is sometimes we have to think without consequences, which of course I think is a radical's credo, but for me it was always very hard because I always jumped to, what are the consequences of the thoughts. But I think sometimes we have to let our minds go, and at academic institutions, if you don't, I think you don't belong there. And so what I wanted to do today was to sort of ask you to let your minds go and to imagine, our future in terms of what we're doing now. And I think that the reason that's important is because if people like you don't do that, then those of us out there in the general society are not going to benefit in terms of being prepared for the future. I think that NIOSH has, like all of the other federal, state agencies, and all of us have been changed somewhat by the events of September 11, 2001. Not only from the fact that 2,886 workers lost their lives during those events in New York and Washington, but also in terms of what that meant in terms of preparedness and response for other workers who we are now involved with trying to safeguard. And I think from NIOSH's perspective, the nation's emergency responders are probably our #1 concern now, as well as others in the general workplace. And I just wanted to give you a little bit of briefing about 5 areas that I think are important, not only in what we're doing in this area, but what it means for the future. The first area I call advancing the design and the selection and the appropriate use of personal protective equipment, namely respirators. If you look at all of the work that has been going on within NIOSH, it all boils down to taking a technology that started out in the 70s and I don't think has moved very much beyond the late 70s. And now looking at this technology in a whole new light. NIOSH is engaged in a process way with taking all of its certification standards for respirators, because NIOSH is respirators are us, and taking all of those uses for industrial uses and now saying, is that respirator good enough for CBRN use, for chemical, biologic, radiological, and nuclear exposures. So all the certification standards are being rewritten. And not only that, but they all have to be rewritten yesterday. NIOSH has completely rewritten its certification standards for SCBAs, for air purifying respirators, and is now probably, hopefully this month, ending its certification standard preparation for escape hoods, those things that you put on and run out of a building to escape the atmosphere inside the building. I think all of those issues relative to the design and the selection imply something about our future. As I said, I think respiratory technology has been stagnant for 30 years. I see it moving now. The issue about what a respirator tells you in terms of its end-of-service life indicators, in terms of its filtering mechanism, what you're depending on. Is there anything on the outside of the mask, the inside of the mask can tell you, change me, I'm running out of my life? No, there isn't any, but that's an issue. Sensor technology. Is there anything on the inside of the mask that's flashing in your eye on the periphery telling you what you're being exposed to? Or the fact that you should exit that environment even with the respirator on, that you're experiencing breakthrough. This whole area of sensor technology I think will be stretched in the near future. The idea of integrated ensembles for first responders so that they have the ability to communicate each with each other in these types of incidents where structural collapse, debris, et cetera, is going on, fire, explosion, chemical, whether everybody's in a respirator. That whole idea of the ensemble being integrated. The ensemble itself is out of date. It's too heavy. It's great if you run into a burning building and you're in there for a couple minutes and you run out. It's not so great if you spend 3 months at the World Trade Center. It doesn't work for those situations. The ensemble that firefighters have worn for 40 or 50 years is being challenged, has to be changed. The second area in this terrorism preparedness, I think that's important, is innovating and applying new methods for detecting and measuring bioterrorism agents. You know, the physicians get all excited. They go and they take the blood or they take the urine or they take something else to determine an x-ray or whatever. Yeah, this patient has been exposed to anthrax. This patient has anthrax. This patient doesn't. But what about the environment that those workers are in? Still today, more than 2 years after September 11th, the Brentwood Post Office is still closed. Post offices for the White House, the State Department, et cetera, are still closed. Who can tell those workers that those workplaces are safe to re-enter? We're going to have a hearing on the 30th about that issue. Congress is still asking, how do we know those places are safe? The idea that we are not there to be able to figure out how you sample for biological agents that are used in terrorism on a surface, in a building, in a workplace, in the Senate Hart building, in a post office. We have very little capability in that area, and we are behind in that area of environmental sampling for biologics. We can tell whether a person has been infected or whether they have the disease arising from that agent, but the idea of sampling their environment is still somewhat primitive. And I think some of the work that I've seen going on here at the University of Cincinnati lends itself to those solutions. And I think everybody wants those solutions. The Environmental Protection Agency and the urging of the President has set up a BioWatch system where within large metropolitan centers in the United States there are sensors that will detect chemical, biological, radiological agents. Well, they're not doing it in real time yet, but nevertheless we need to move in that area. What if they sense something? What do you sample? How do you sample? How do you get the results back immediately? Because the time is of the essence in order to, which is the issue with any kind of weapons of mass destruction. The destruction may never take place in the case of chemical biological agent, but the disruption, the agent as an agent of mass disruption will occur, and you'll have a population that is scared, psychologically needing of reassurance, and you can't say it's in the lab. We're waiting for the result. That day is over. That's not the normal anymore. The new normal is, what is the answer? I want it now. And so we're going to have to design methodologies that produce those kind of answers in the here and now and not in the tomorrow and later. The other issue, I think the third issue in bioterrorism and terrorism preparedness that NIOSH has been involved in that I think is extremely important is the idea that if you look at global patterns of terrorism, you'll find that 98% of them occur in workplaces, regular workplaces. They don't occur in fancy government buildings. They don't occur in embassies, but they occur in regular workplaces or residential places. Well, if 98% of events occur in a workplace, like you and I inhabit, then it's incumbent on those people who protect the health and the safety and now the security of that building to protect you from agents entering this building through the ventilation system here, as we're all sitting here like sitting ducks for things to enter the ventilation system. How can that ventilation system sense what's coming in? How can the ventilation be shut off? How can it reverse itself? How can the portals to the ventilation system be protected? NIOSH has written 2 technical publications with the Office of Homeland Security on this issue. And this is an issue that arose in the Salt Lake City Olympics, in which a lot of these methodologies were tried in the buildings that were going to be used in the Olympic Village there because of that issue. And I would say to you that that is the new normal for any building where any public gathering takes place from here to I don't know when. Is that building secure? What is the mechanics of that HVAC system? Are there sensors in place? How fast can the filters be activated? And how efficient are the filters? And how can the machine be shut off? So I think those issues are going to push us in the next 5 to 10 years. NIOSH, sort of on the fourth issue, is working with the rest of CDC and with Homeland Security in enhancing its emergency response database. And one of the problems that we have there is if you look at the NIOSH Pocket Guide and you look at this family of TICs, toxic industrial chemicals, this is the lingo now, TICs and WMDs, weapons of mass destruction, TICs and WMDs. And then you look at IDLH values in the NIOSH Pocket Guide, you'll find that those that could be used as agents in a terrorist attack, that about a third of them don't have IDLH values. Well, this is important information to know. NIOSH is behind the 8 ball, and of these 400 or so, a third of these don't have it, and we have to generate IDLH values in order that this emergency response database be as good as it can be. And not only that for a national audience, but increasingly all of our technology and development in this area is being exported internationally. And people in both developed and developing countries look to the United States for this kind of guidance. The fifth area has to do with medical monitoring of workers that have been exposed. Now, right now, our baseline are some thousands of workers or volunteers from the World Trade Center site who were exposed to God knows what in the process of responding and cleaning up the World Trade Center site. Those workers now, through several generous grants from NIOSH of $90 million apiece, to centers like the clinics that exist at the University of Cincinnati and a consortium of clinics headed by Mount Sinai in New York are looking at those workers to figure out what their health status is, both baseline, the first 90 million, and an additional 90 million for the future, perhaps only for 5 to 10 years, as Senator Clinton would say to us, and we have to think about the next 10 or 15 or 20 or 25 years in terms of latent effects associated with cancer. If you look at Mount Sinai's existing, in January we had a news conference in Mount Sinai, you look at the first 500 people that went through their clinic, and you take the 250 of them by random selection, and you look at their symptomatology, and presumably this is what we have right now, you'll find about 50 to 60% of them still, after 18 to 24 months, have persistent respiratory symptomatology, still have musculoskeletal disorder issues, and still have psychosocial issues. Those types of medical monitoring issues will remain with us for many years until the lifetimes of these people expire. I think that what that medical monitoring situation has done is a number of things. The most interesting one for me has been going to several of those clinics and sitting down with firefighters and others and listening to their story with regard to their post-traumatic stress symptomatology. You know, before September 11th, I sort of sensed, I think, and with good empirical reason, that post-traumatic stress disorder was really not something that was well accepted in those types of settings that you would probably expect to see a large prevalence rate in military operations, paramilitary operations, civilian emergency responders. But I think one of the sidelights to the 9/11 situation, the medical monitoring situation of World Trade Center workers, is post-traumatic stress disorder has achieved an importance amongst a population that it never before would have. I think that all of these issues are going to affect us. In addition to these rather dramatic issues that we're facing with regard to emergency preparedness and response, I think there's a number of others that have gone on before September 11th and will continue on. And I think one of the most important ones has to do with the evolving organization of work and the effect that that work is either having or associated with or can have on conditions that we, I think somewhat of as intangible. the effect that the way work is organized, management styles, downsizing, compressed time frames, et cetera, et cetera, et cetera. Think of all these management risk factors and then figure out what are we talking about in terms of health effect. If you look at cardiovascular disease, hypertension, you look at musculoskeletal disorders, psychosocial disorders, the incidence of depression amongst men and women in the workplace. How are these factors related to the way work is done? And I think this area will take us into new and uncharted territory. And if you look at how these areas will influence our world in the world of occupational safety and health in the next 5 to 10 years, I think you could look at the World Health Organization's prediction with regard to depression being in 2010 the second leading cause of chronic illness in the workplace. Now that's rather a startling statistic. What are employers, what are occupational safety and health doing to look at the issue of depression and its causation factors or exacerbation factors within the workplace? If you look in the Occupational Safety and Health Act itself, and you look under what NIOSH is supposed to do, what I found absolutely riveting when I first read it was the word psychosocial is in the Act written in 1970. So it's very unusual when you find in your enabling legislation a word that actually describes where you're at in the present time, because statutes tend to age, and not well, through time. But it's fascinating that that word is there. And I have asked people who were alive and writing the act during that time who chose that word. And I still haven't ferreted that out. I think the other issue, or the next issue that we should stretch our minds around, and that's the issue of how we can make the American workplace culturally competent. And what I mean by that is the whole face of the American workplace is changing. That when we look at each other, we see a lot of differences. We see a lot of diversity. And I think that if you look at the BLS statistics in the year 2000, you'll see that the issue about immigration is affecting the workplace. You look at certain states that are not known, like California, New York, Florida, Texas, not those states, but Tennessee and Georgia and North Carolina. You look at their percentage increases in Latinos, for instance, 150 to 300% increase in the workforce. You look at agriculture, construction, manufacturing in those states, and you see something that I've seen in California for many years. You see a lot of different ethnicities in the workplace. And I think this will challenge us. The increasing number of women, not only in child care and health care and teaching, but also in other professions, I think will also challenge us, and the issues of reproductive issues in the workplace will increase. The increasing number of people with disabilities who choose to and are allowed by the Americans with Disabilities Act and are encouraged to remain in the workplace, I think that's a significant issue. So that we all, I think, need to pay some attention to increasing the cultural competency of the workplace so that the American workplace can function well in a highly diverse ethnic, sociocultural environment. And I'm not sure that we're there yet, and I think it is a legitimate issue for safety and health. The other issue that I want to talk to you briefly about is this connection that I think we need to make between health protection activities, which are those traditional occupational safety and health activities that we have engaged in for years, that we have occupational safety and health regulations about, versus the health promotion activities that a whole other community of people, although I will grant you that the occupational nurses community and profession has spent more time trying to bring these two worlds together than anybody else, but this whole idea of lifestyle factors and how they influence health protection. Just this morning, I looked at a poster today about obesity and the effect of solvents in terms of fat distribution, et cetera. There is an obesity epidemic in the United States today. I am forced to wear this pedometer here on the side of my belt because my Secretary of Health and Human Services has launched a Steps to a Healthier U.S. And he checks it at the end of the week. This initiative is vitally necessary. And it's so necessary that I said NIOSH needs to participate. And we need to have a Steps to a Healthier U.S. workforce. Because we know, all of you know, and some of you research this, that there are these connections between the obesity epidemic, the diabetes epidemic, and these lifestyle issues, tobacco, smoking, etc., exacerbate occupational exposures and can produce synergistic effects and additive effects that we need to attack from a unified way. Now, are we unified? No, I would say not. If you look at the medical costs of people with chronic disease, it accounts for 75% of the nearly $1 trillion that are spent every year in America. 75% is chronic disease. And we, as occupational safety and health people, need to be a part of the solution to solving that drain on the U.S. economy. I think that NIOSH is well suited to do that. We're going to be putting together a symposium in 2004, trying to bring together the communities of health protection and health promotion and solicit all of your ideas with regard to that. One issue that I have to mention also, which has to do with the world that I inhabited for 12 years in the occupational safety and health arena, and now in the NIOSH arena, is the issue of occupational exposure limits. And all of the work that researchers do, especially in the chemical area, but also now in the biological area, setting exposure limits, saying, this line says, if you're exposed to this for 40 years or more, every day of your life, you're fine. If you go over this line, you're not. Well, there's a whole structure in America. The Occupational Safety and Health Act itself has methodologies by which these limits can be taken and turned into permissible exposure limits or legally mandated. It's a 30-year, 33, 35-year-old structure we have. Well, if you look at the permissible exposure limits that were generated by ACGIH TLVs in 1970 that OSHA adopted in 1972, that lasted for a few years, and then there's no mechanism in the statute that requires update, so OSHA tried to update them all in '89. The 11th Circuit Court of Appeals threw it out the window, said no, you can't do it. Those PELs are now 30-some years old. We live, whether we like it or not, in a post-PEL world. Those PELs are old. And I would challenge any industrial hygienist in the audience that tells me that they go and they advise their employers, here, this is the PEL you should use. Because that would violate an industrial hygienist's professional oath, a physician's professional oath, a nurse's professional oath. So the reality is we live in a post-PEL world. We have not collapsed, if you notice. We still improve people's safety and health. We still see a declination in occupational injury and illnesses and fatalities. So we need to understand, while the American Industrial Hygienists Association spends some time on trying to update PELs, carrying, the bucket up a very steep cliff, we need to figure out, well, is this really the way we should go? Should we sort of decide, well, should we spend all of our precious resources on determining whether 0.3 or 0.2 is the best level, and generating a whole structure of epidemiologists and toxicologists to give us that information? Well, there are other ways. The Europeans have said, enough of that. We are going to do control banding in the United Kingdom. We're going to take sort of a spectrum of exposure. We're going to say, if you're in there, then we're going to spend our time and effort in telling you how to control that. Okay? Solutions, creativity, innovation in terms of control rather than in setting the standard. The other issue I wanted to talk to you about is the increasing role that I think, and this university, as I got lost going to the men's room, I noticed a number of offices that have the word genomics on the front of it, and having heard about a little bit about what you do, I think the world of not only genomics, it's too static. The gene structure is too boring. It doesn't really give you enough information. But proteomics, and then metabonomics as the next step. Those three, genomics, proteomics, metabonomics, I think all of them will so push the world of toxicology in the future that biomonitoring of 5 to 10 years from now will not look anything like the biomonitoring that we're doing now. No offense to the toxicologists in the audience, but when I took toxicology, I sort of thought, you know, it's kind of like hitting the animal over the head with a baseball bat and sort of deciding which organ falls out first. If you imagine toxicology for the future, you see an entirely different kind of toxicology. You see microarrays, elegant, sophisticated ways of determining whether a subtle effect of this particular agent has happened to that organism's cellular or subcellular structures. This is a whole another word I think world we're just on the verge of. Meanwhile, the Senate, you know, on Monday or whatever, beginning of the week, finally got the genetics discrimination bill out of the Senate. It's now in the House. This idea that somehow we're going to protect the workers from being discriminated against genetically. We're going to protect these workers from this information that's going to come out. The pressure, I think, from this new world of genomic, proteomic, metabonomic genetics and toxicology is going to really strain the limits of any legal protections that are going to be out there. And I think that the medical legal issues will be significant. The issue of occupational health services, I think, is another one that we're going to have to spend some time on. If you look at any state, if you look at the state that I'm from, Florida, any of these states, this worker compensation system is failing. And it's failing because the medical services part of the occupational and the workers' comp system is having some problems. We need to better define the quality of medical care. What is quality care in terms of an MRI for a back injury? We know what that is. There's oodles of prominent associations and societies that have determined that, and they've even been adopted by the purchasers and the providers, Medicare, et cetera. Well, do we have that in occupational health services? No. I think there's a lack of agreement about which constitutes high-quality worker comp medical care, and I think we need to get there. The interaction of workers' compensation and other health care programs, hardly anybody studies that, except the Robert Wood Johnson Foundation, NIOSH, and the Workers' Comp Research Institute. But I think we need a lot more thinking on how these systems interact. The working poor have workers' comp and Medicaid programs. The chronically disabled have workers' comp and Social Security. Community clinic patients may even have worker comp injuries that are put into that system and not the general health care system, and they may have this overlap of lifestyle issues that they are now being purchased by the worker comp insurers. And certainly employees of small employers frame medical problems often as worker comp problems because they are part of the large uninsured. And I think this whole issue about what is work and health and how it can work together. What is workability? What is that ability that we start out our working lives and we go into a system that actively assists us in maintaining our workability until we retire so that we can have an enjoyable, productive retirement? Sounds European to me. But that exists actually in some European thought. And I think that we need to, in the United States, think about how we can better integrate work and health. The last thing that I wanted to bring to your attention is the issue of communicable diseases as an occupational safety and health issue, and indeed as a sustainability issue. You know, we know that for those of you that do biologics and mold and other things in the workplace, the effect that that's had on the workplace. And we need to do a lot more in that area. We need to find out what the health effects are. Can we measure anything? I was part of, or the object of legislation in California, the Toxic Mold Act of 2001, which the legislature thought would be a good idea. And they said, we want you to develop a permissible exposure limit for mold. Well, you know, that doesn't work. There's no science there. We need to look at that. But above and beyond those kind of things, we also need to look at the effect that a communicable disease can have on the structure of the workplace itself. If you look at the African AIDS issue now, and you'll find some rather startling numbers I think you're all aware of in terms of life expectancy, et cetera. Multinational corporations doing work in Central and Southern Africa have a sustainability issue. They cannot find workers to work. The issue of the African AIDS is quite dramatic, but it raises the issue about Can you move African agriculture ahead if you don't have workers who are agricultural workers because they've died? Can you move African mining ahead if you don't have miners that work? This idea that communicable diseases can actually affect a significant amount of the economy. I think when it was in Africa, there was some interest. I applaud the Gates Foundation, President Clinton, President Bush. Everybody has realized $15 billion from this administration to the Global AIDS Fund. But look what happened with this outbreak of severe acute respiratory distress, or SARS. Does your workplace have a SARS infection control plan? So look what the $50 billion effect of SARS did in a very short period of time. Closing airports, closing countries. This was a dramatic illustration, I think, of two things. One, in near record time, the SARS coronavirus genome was sequenced. That would have never happened prior to the year 2000. And that will, I think, be, again, an example of how the genomics is pushing our knowledge base forward, so our response time is much shorter. But look what SARS did internationally. And I think that that's going to affect all of us if we have another SARS outbreak. Now, if we've eradicated SARS from the existing civet populations in China and Vietnam from whence it arose, fine. If we haven't, we have a problem. So we need to be prepared for that, and we need to be teaching our employers and our workplaces about infection control plans as they would be taught about any other safety and health issue. We need not, I think, leave that issue to the infectious disease folks. We need to own that issue, and it needs to be an occupational safety and health issue. So these are just, I think, some of the thoughts that I have for you today. As I say, they are without consequences in the sense of you owning them. Think about them, and I hope that your seminar goes very well here the next 2 days, and I really appreciate the invitation to come and see your wonderful program and your beautiful campus. Thank you.